Welcome back, everybody, for another deep dive. And today we're going to be tackling something that I'm sure you guys run into all the time in your practice. We're talking about hormone therapy. We've got a fantastic research article here from Circulation, really digs into the latest thinking on this. And especially for those patients who have cardiovascular risk factors, always a tricky thing to balance.
Yeah, it's a really comprehensive review. And one of the things that really jumped out at me was how much they emphasize this, the timing hypothesis. I'm sure you're familiar with it, but the evidence they present here is really pretty compelling.
Yeah, that was one of the things that really caught my eye too. This idea that the timing of when you start hormone therapy really seems to significantly impact that cardiovascular risk.
Mm-hmm.
It's something we really need to unpack, I think.
Absolutely. And the authors of this circulation article, they really went deep, analyzed data from numerous studies, and
Yeah.
the findings are pretty clear, for women under 60. Initiating hormone therapy within 10 years of menopause, it's associated with a substantially lower risk. We're talking like a 40% lower risk of stroke compared to those who started it later.
40%. Wow. That's huge. I mean, that really is a game changer when you're sitting down talking with a patient about their options.
Yeah.
It really makes you rethink some of those, maybe those blanket recommendations we used to have.
For sure. And it really, I think, underscores the need to move away from just thinking about hormone therapy as like a yes or no question and really delve into the nuances of the timing and the individual patient's profile.
Absolutely. And speaking of nuances, the article doesn't just stop at the when, it also gets into the what. Like, what type of hormone therapy are we talking about? And I got to admit, I was surprised by some of the distinctions that they highlighted,
Hmm.
especially when it comes to routes of administration.
Yeah, I mean, moving beyond just sort of the simple systemic versus local, the choice between oral and transdermal estrogen, it turns out to be far more significant than I think I initially realized. And the circulation article does a really great job of breaking down the impact that these different routes have on things like lipid metabolism and coagulation factors.
Yeah. I've always known that with oral estrogen, you have that first pass effect through the liver. But I don't think I fully grasped how that specifically increases triglyceride levels.
Right. And by contrast, transdermal estrogen bypasses the liver and has a much more neutral effect on both triglycerides and those clotting factors.
Hmm.
And that has huge implications when we're thinking about patients with dyslipidemia or those already at higher risk for blood clots.
Yeah. I mean, it's almost like you need a cheat sheet to keep track of all these specifics. I
Yeah.
know for me, table 5 in the circulation article was super helpful. It really laid out visually, how these different hormone therapy types impact lipid profiles.
Yeah, that's a really valuable resource for sure. And it highlights how that transdermal estrogen consistently demonstrated a more favorable lipid profile compared to oral estrogen, even lowering triglycerides in some studies.
Wow. This is the kind of information that really directly impacts our day-to-day practice. Makes you want to go back and double check which type of hormone therapy your patients are even on.
Absolutely. And it emphasizes the importance of that shared decision making. We need to be able to clearly articulate these nuances to our patients so they can make informed choices that align with their individual risk factors
Yeah.
and their preferences.
Okay, so we've established the timing hypothesis is key, and we really need to pay close attention to the type of hormone therapy we're prescribing. But how does this all play out, in the real world with those complex patients that we see every single day?
Right. That's where it gets even more interesting. The circulation article goes on to really delve into some specific patient scenarios and highlights the challenges and considerations for each. So let's start with obesity. It's a significant risk factor for cardiovascular disease. And unfortunately, it's something that we see quite a bit in our patient population.
Yeah, that's a big one. I've always been really cautious about prescribing hormone therapy to patients with obesity, just knowing that it independently increases the risk of blood clots.
Yeah.
You don't want to add to that.
Yeah, it's a valid concern, especially when you're considering oral hormone therapy, because adding that to the mix can further elevate that risk.
Right. But the article did point to some encouraging findings regarding transdermal estrogen. It seems like they consistently observed a lower risk of blood clots with that route of administration, even in obese patients.
That's right. Transdermal estrogen appears to offer a much safer option in this scenario because remember, it bypasses that first pass liver metabolism and its associated impact on those clotting factors.
Okay, that's a sigh of relief.
Yeah.
It's good to hear some good news, for this patient population. I mean, obesity is such a widespread issue, and having a potentially safer hormone therapy option is really significant.
Absolutely. And it just highlights the importance of, staying updated on these nuances
Mm.
because what we thought was a blanket contraindication may actually have some really viable alternatives based on the latest research.
That's a great point. Speaking of challenging scenarios, the circulation article also tackles managing hormone therapy in patients with dyslipidemia, another area where those different estrogen routes seem to make a big difference.
Yeah, the lipid paradox of hormone therapy is fascinating. While estrogen can have these beneficial effects on cholesterol levels, it can also increase triglycerides, particularly when it's administered orally.
Right. I remember seeing that in Table 5. The data from those 11 randomized trials were pretty clear. Transdermal estrogen actually lowered triglycerides, but oral estrogen raised them.
It's a striking contrast for sure, and it reinforces the need to really tailor our approach to the individual patient's lipid profile. If we've got someone with high triglycerides, transdermal estrogen becomes, the clear front runner.
It's all about minimizing those cardiovascular risks wherever we can.
Hmm.
And, choosing the right route of administration, it just seems to be such a crucial piece of the puzzle.
Absolutely. The circulation article then moves on to address hypertension, another common comorbidity we encounter.
Right.
And while the impact of hormone therapy on blood pressure is still somewhat debated, the WHI trial did show a slight increase with oral estrogen.
Yeah, and, even a small increase in blood pressure can be significant when we're talking about long-term cardiovascular health.
Absolutely. So we really need to proceed with caution when considering hormone therapy for women with hypertension. In cases of severe, uncontrolled hypertension, it's even considered a relative contraindication.
Yeah, it's a good reminder that, hormone therapy isn't a one-size-fits-all solution.
Yeah.
We need to carefully weigh the potential benefits against those risks, particularly for patients with these existing cardiovascular conditions.
Absolutely. Now let's shift our focus to another patient population that always requires careful consideration, those with diabetes.
Oh yeah, that's a complex issue for sure.
Yeah.
I mean, women with diabetes already face an elevated risk of heart disease,
Yeah.
and they often experience worse outcomes after a heart attack compared to men.
Exactly. And the relationship between hormone therapy and diabetes isn't straightforward. While some studies have shown positive effects on glucose control and insulin sensitivity, those benefits haven't consistently translated into a reduction in those cardiovascular events.
Okay, so where do we stand then in terms of recommendations for our diabetic patients?
Well, the WHI trials didn't reveal an increase in mortality or cardiovascular events with hormone therapy in women with diabetes. However, considering the heightened risk associated with common comorbidities like obesity, hypertension, and hypertriglyceridemia, the transdermal route of estrogen therapy is generally considered the safer option.
Okay, so again, it seems like minimizing risk is kind of the recurring theme here. Choosing that delivery method that's least likely to exacerbate those existing cardiovascular risk factors.
Precisely, and the circulation article goes on to discuss metabolic syndrome, another cluster of conditions that significantly amplifies the risk of heart disease. In this case, the WHI trials actually revealed a concerning twofold increase in cardiovascular risk for women on oral hormone therapy.
Wow, that's a red flag for sure. Given the increased risk of blood clots already associated with metabolic syndrome, adding oral estrogen to the mix seems like a recipe for trouble.
Yeah, it
Yeah.
really does. No, while there aren't specific studies directly comparing systemic and transdermal hormone therapy in women with metabolic syndrome, the transdermal route emerges as the likely safer bet based on the existing evidence.
Okay, so we've covered a lot of ground here. From the importance of that timing hypothesis to the nuances of choosing the right type of hormone therapy. For all these different patient populations, what are the key takeaways that we should really be emphasizing in our practice?
Well, first and foremost, individualizing care is paramount. Each patient's age, time since menopause, cardiovascular risk profile, personal preferences, and treatment goals need to be carefully considered. There's no room for a cookie cutter approach here.
And it's so crucial to remember that open and honest communication with our patients is essential for that shared decision making. They need to be fully informed about the potential benefits and risks of hormone therapy to make choices that align with their values.
Absolutely. Empowering our patients with knowledge is just as important as prescribing the medication itself.
I love that. Now, the circulation article also offers some guidance on, monitoring hormone therapy discontinuation and the possibility of extended use.
Right. It's important to reevaluate the need for hormone therapy at least annually or whenever a patient's medical history or symptoms change. Generally, after a few years, especially as those vasomotor symptoms often improve, lowering the dose or discontinuing therapy altogether is reasonable.
Okay. But we shouldn't let age be the sole factor in deciding when to stop, right? The article emphasizes that extended use might be appropriate for women who started hormone therapy within 10 years of menopause and still experience those persistent vasomotor symptoms or have concerns about osteoporosis.
That's right. But we need to be clear that extended use in this context is different from initiating hormone therapy in women over 60 or more than 10 years past menopause. It's that initial timing that carries the increased cardiovascular risks we've been discussing.
Got it. And for those considering extended use, we need to have a frank discussion about the potential increased risk of breast cancer with that prolonged combined estrogen-progestin therapy.
Absolutely. Transparency and shared decision making are paramount in those situations. And as always, opting for that transdermal route of estrogen, particularly for older women, can help minimize that risk of blood clots.
Okay, now the article also outlines situations where hormone therapy should generally be avoided. This includes women with a history of coronary heart disease, blood clots, stroke, certain types of heart disease, and uncontrolled cardiovascular risk factors.
It's a reminder that while hormone therapy can be a valuable tool for managing those menopause symptoms, it's not without its risks. We need to carefully assess the individual patient's situation and weigh those risks against the potential benefits.
And in cases where systemic hormone therapy isn't appropriate, local low-dose vaginal estrogen remains a safe and effective option for treating those genitourinary symptoms of menopause.
That's a good point. It's important to have those alternative treatment options in our toolbox. For those patients who aren't candidates for systemic therapy,
This deep dive has been incredibly insightful, shedding light on the latest thinking on hormone therapy for women with cardiovascular risk factors. But as with any complex medical topic, there's always more to explore.
this deep dive has really focused primarily on those cardiovascular risks. But what about the impact of hormone therapy on other aspects of women's health?
Yeah, that's a great point. I mean, we spent a lot of time talking about the heart, but hormone therapy's effects extend far beyond that.
Exactly. One area that's generating a lot of interest is the potential impact of hormone therapy on cognitive function.
Oh, interesting.
Yeah, some studies suggest that initiating estrogen therapy closer to menopause might actually offer some kind of protective effect. But, we definitely need more research to confirm that.
Right, and we can't forget about bone health. I mean, osteoporosis is a major concern for women as they age, and hormone therapy can really be a key player in preventing bone loss.
Absolutely. In fact, for women at high risk of osteoporosis, hormone therapy might even be recommended, even
Yeah.
if they're not, experiencing significant vasomotor symptoms.
Wow, so it really highlights the decision to recommend hormone therapy. It goes beyond just managing those hot flashes and night sweats. It's about taking a holistic view of a woman's health and really weighing all those potential risks and benefits.
That's exactly right. And that's why, staying current on the latest research and guidelines is so crucial. Our understanding of hormone therapy is constantly evolving, and we need to be prepared to adapt our recommendations accordingly.
I think this deep dive into hormone therapy has been packed with valuable insights. And I hope you feel, more confident in navigating the complexities of those treatment decisions for your patients.
Absolutely. And remember, individualized care is paramount. What works for one woman may not be appropriate for another. We need to carefully consider each patient's unique circumstances and have those open and honest conversations about the risks and benefits of hormone therapy.
Couldn't agree more. And don't hesitate to, reach out to colleagues in other specialties. That multidisciplinary approach can be incredibly valuable in ensuring that, our patients are receiving the best possible care.
Definitely keep those minds sharp, keep those questions coming, and keep digging deeper into this, ever evolving world of hormone therapy.
That wraps up our deep dive for today. Until next time, keep learning, keep exploring, and keep those fascinating conversations going.